Bismillahirrahmanirrahim. So, I welcome all of you in my today's lecture that is regarding the ARDS, that is acute respiratory distress syndrome. So, how do you diagnose the ARDS? So, there is a criteria we must know about that criteria. So, it is very simple, it is very easy to diagnose the ARDS. That is 4 points, that is called Berlin criteria. Point number 1, it is acute in onset. The insult that lead to ARDS is acute. Point number 1, that is a duration of 1 week. Point number 2, there are bilateral infiltrates on the chest X-ray or the CT, the bilateral infiltrates. But these infiltrates are not caused due to atelectasis, pleural effusion, atelectasis, or nodular opacities. Refractory hypoxia. The patient is not maintaining oxygen saturation whatever you do, whether you apply the nasal cannula, you apply the face mask, or you apply the non-rebreather mask. The patient is refractory. The patient hypoxia is refractory. The saturation is not improving. And fourth point is that is non-cardiogenic pulmonary edema. Ejection fraction on the echo is normal, left atrial pressure is normal, pulmonary capillary wedge pressure is normal. So these 4 criteria must be met in order to label a patient to be as a patient of ARDS. Coming toward the pathophysiology, let's suppose this is your alveoli. We have taken the section of that alveoli. We know that there are 6 layers of the alveoli. The 2 most important is the 2 epithelial layer. The epithelial layer on the alveolar sides, that we are having type 1 pneumocytes and type 2 pneumocytes. These are the type 1 pneumocytes I have shown because 90% they are type 1 pneumocytes. And these are the endothelial cells on the capillary side. Suppose we are having blood vessel on this side and we are having air on that side. So how is ARDS caused? ARDS is caused due to insult to epithelium of alveoli. On alveolar side, if the epithelium is damaged due to any cause, or there is damage to the vascular endothelium. On the blood side, we are having damage to the endothelium. What happens whenever there is damage to this endothelium or this epithelium? What happens? The tight junction between them is lost. When the tight junction between them is lost, what happens? There is the leakage of fluids, leakage of proteins. Whenever there is the leakage of proteins into the alveoli, into the alveolar space, what happens? It draws the water from the blood vessels in the interstitial spaces. So the alveoli are filled with fluid. When they are filled with fluid, they collapse. When they collapse, there is vacuum mismatch. There is vacuum mismatch that leads to the hypoxia. Point number 2. There is damage to the type 2 pneumocytes. When the type 2 pneumocytes are damaged, there is no production of surfactants. If there is no production of surfactants, the already present surfactant, when that is absorbed, when that is damaged, or when that is lost, there is no new production of surfactant. So there is collapse of the alveoli. Now what causes the ARDS? We are having direct causes and the indirect causes. Direct causes mean that directly causes entry to the alveoli, that are the pneumonia, whether bacterial pneumonia or the viral pneumonia, nowadays the COVID-19, influenza, respiratory syncytial virus, or the bacterial pneumonia, community-acquired pneumonia, hospital-acquired pneumonia, or ventilator-associated pneumonia, whatever is, but that is direct cause. Gastric aspiration, directly digesting the alveolar epithelium. The indirect cause is the sepsis, the acute pancreatitis, tissue trauma, and the massive transfusion. What they cause is, they cause a massive release of inflammatory cytokines, and these cytokines, they comes through the blood and they attack this endothelium. When they attack this endothelium, the junction between the endothelium that is lost. When that is lost, what happens? There is the leakage of the fluids inside, and there is the leakage of the inflammatory cytokines toward the epithelium sites, and they also destroy the alveolar epithelium. So the fluids, the proteins, the inflammatory cytokines, they move toward the alveoli and causes the collapse of the alveoli, leading to ARDS. What is the management? Just like a patient is having fever, What do you do in acute setting? Do you give antibiotic or you give antipyretics? The answer is antipyretics. So we have to manage first ARDS, then the cause. So first we have to give antipyretics. The antipyretics in this case is you have to improve the hypoxemia. How do you improve hypoxemia? When the person is a candidate for ventilator, but unfortunately in majority of the cases the ventilator is not available, so you can use the CPAP and the BiPAP. And if ventilator is present, how can you take advantage of it? You have to turn on the lung protection mode. With the lung protection mode, well, there is already going on damage, so if you are not using the lung protective mode on the ventilator, you are actually killing the patient. You have to use these parameters. You have to use the low tidal volume. You have to use the low FiO2, less than 60%. Why? Because if you give more FiO2, there is probability of free oxygen radical generation, and that destroy the alveoli more, and that exaggerate the condition more. Low plateau pressure, because you have not to burst up the alveoli, and you can give a PEEP more than 5 centimeters of water, so that PEEP actually open and pop-ups the alveoli, that recruits more the alveoli, and that make the alveoli free of those fluid that is already come into the alveoli, and that also improve hypoxemia by the recruitment of alveoli. So the mortality rate is very high, that is more than 50%, even if properly treated. But along with that, you have also to take care of the cause. You have to treat pneumonia, you have to treat the respiration, for the respiration of course, and you have to address the cause if possible. Now there is classification of the ARDS also. We are having mild, moderate and severe, and that is based on the PaO2 divided by FiO2 ratio. So if normally that is more than 300, but that ratio should be taken when the person is on ventilator and the PEEP is more than 5 centimeter. The PEEP is more than 5 centimeter, patient is on ventilator, and you have to now classify the ARDS, mild, moderate or severe. Now you take the ratio PaO2 divided by FiO2. If that is 200 to 300, this is mild. If that is 100 to 200, that is moderate. If that is less than 100, that is severe ARDS. What if the PaO2 is not possible? What is the alternative? What if you are not able to take the EBGs of the patient? Well, it is said you can take the ratio of saturation of oxygen. The saturation we measure by the pulse oximeter. So saturation of oxygen divided by PiO2, saturation of oxygen divided by FiO2. So you take the ratio of that, saturation of oxygen divided by FiO2, and apply those reading, mild, moderate and severe. So thanks for watching, and if you have not subscribed my channel, please subscribe my channel.